Hello, I'm Elyse Gellerman from the Neuroendocrine Tumor Research Foundation, and I'm talking today with Dr. Mark Lewis from Intermountain Healthcare in Salt Lake City. Dr. Lewis is a NET patient and a GI oncologist. He's also a member of our NETRF Board of Directors. Dr. Lewis, thanks for spending a few minutes with us today to answer some of the questions we're hearing from NET patients and their families. I think it's very important to try to get as much information out. We know everything is changing, and there's certainly a lot of fear and uncertainty about COVID-19. So thank you again for spending some time.
Oh, my absolute pleasure and privilege, Elyse, and I'm thrilled to be able to address your audience virtually. You know, we're obeying social distancing right now. I think we should, definitely timestamp this conversation on April the 3rd, because this is such a rapidly evolving situation that, information can change almost literally overnight. But I think some of the points that we'll cover should remain relevant in the weeks to months to come.
Wonderful. Well, let's start right in. I know one of the questions that we're getting from a lot of patients is, are NET patients more vulnerable to COVID-19 because of either their tumor site or their stage or the prior treatments that they've had?
Right. So there's no blanket answer to that question. And, I will insert the caveat that individual results will vary, and really things are determined on a case-by-case basis. But I will say this, the first group that might come to mind as at higher risk would be patients with lung or bronchial NETs, because we know that the coronavirus, when it takes hold in COVID-19, which is the actual disease, it can be very mild upper respiratory illness, or it can be very serious lower respiratory tract illness, where it gets into the lungs and causes a very substantial bilateral pneumonia. And that's where the cases of increased oxygen requirements and patients needing to be intubated and placed on ventilators, that's where that comes into play. However, the virus descending to that part of the lung has a very specific binding point to something called the ACE2 receptor. And it's really not clear that patients with lung NETs would be at any higher risk for that binding than anybody else. I will say, however, that any patient that's on everolimus, which can include patients with lung NETs or other NET sites, they're potentially at risk for pneumonitis. So they might have an existing lung defect, if you will, that puts them at higher risk, not necessarily for the virus, but for respiratory complications. So I think those are the things to keep in mind. And then in terms of grade, higher grade NETs tend to require stronger treatment, by which I mean chemotherapy that can affect the immune system. So I think it's really important for patients and their families to know, ideally through conversations with the doctors or either accessing the medical records, if there's any evidence of suppressed immunity. And specifically, I'll get very granular. If you have access to your complete blood count, if you look at the lymphocyte count, so the complete blood count contains a measurement of the white blood cells, and then typically those are broken down into individual component types of white blood cells. And the ones that really matter in terms of viral defense are the lymphocytes. So these are the same T cells that get low in HIV and AIDS. So we know from that experience that those patients were more susceptible to opportunistic infection. So it's a little bit of a different scenario with this viral pandemic. But the long answer to your question is any patient, any NET patient who's on treatment that either can affect their lungs or lower their lymphocyte count, I think would be at slightly higher susceptibility to COVID-19.
We've also had a question from patients about what it means to be immunocompromised. And you just talked about the patients who would be at higher risk. What about someone, though, who had prior surgery or had their spleen removed? Does that make them immunocompromised right off the bat?
Right. So the spleen is a really interesting organ. As we know, you can survive without it. And in terms of infection, it actually has very specific role against what are called encapsulated organisms, which are bacteria. So pneumococcus, meningococcus, and Haemophilus are the bacteria that the spleen sort of typically handles for us. So if you've had your spleen out, you've almost certainly been vaccinated against those things. However, the good news I suppose, is that it shouldn't increase your risk against COVID-19 if you'd had a splenectomy. The caveat here, Elyse, I think, is if you've had very recent surgery, that means you've probably been in a healthcare facility, and unfortunately our hospitals are increasingly becoming, if we're not extremely careful, nodes of transmission because patients are gathering here. And secondly, it's possible, somewhat theoretical, that your immune system is being diverted to healing. That's really getting a little bit nebulous. But on the whole, I would say that surgery in particular doesn't seem to increase risk.
And Dr. Lewis, what about if patients have had PRRT or chemotherapy recently, say since the beginning of the year? How long does it take their immune systems to recover?
That's a great question. So chemo and PRRT are very different in how they impact the immune system and how quickly. So with most chemo, and we talk about cycles, and the reason that we cycle most chemo is to allow recovery of the immune system. So there are, in the net world, just like there's a wide spectrum of patients, there's a wide spectrum of treatments. And so some treatments, and I'm thinking here about, say, platinum-based chemotherapy for high-grade NETs, or neuroendocrine carcinomas, I should say, that can have a very acute drop in immunity. So for instance, if I give someone platinum-based chemo this week, and I'm typically cycling it 3 weeks, that second week when they're off treatment may actually be the low point in their immune system. So they hit kind of a trough, and either on their own or with assistance from us through growth factors, they then come out of that trough and crest again just in time to do the chemo again 3 weeks later. So that's one example of chemo and how the ebb and flow of the immune system can happen between and after cycles. PRT is a bit of a different animal. We know that just under 10% of patients undergoing PRT will develop the low lymphocyte counts that I mentioned earlier, but that can be quite latent. PRT is, on the one hand, the gift that can keep on giving, so the therapeutic effect of the PRT can occur for quite a long time after the radiation is done. But by the same token, the effect on the bone marrow can also be very long lasting. And so really the only way to know that is to have your blood count tracked during and after PRT. We're trying not to bring people to major hospitals for blood counts if we can avoid it. And again, a complete blood count is a blood test that can be done almost literally anywhere. So let's say you came to a tertiary medical center for your PRT and you're now back at your home clinic. That might actually be a place that you can do your blood work and then have that routed to your NET oncologist.
Thank you. One of the other, I think, discussions that we have seen of late and questions that we've had from patients, those on SSA injections, and how should patients weigh the risk of going somewhere or having someone come into their home to give them that injection versus not having it and skipping a month or so. And along with that, what about scheduled scans?
Right.
So how are you having those conversations with patients, and what do patients need to think about?
Sure. So I think for the functional patients, the patients that are really dealing with syndrome, we already know that for some people, 28 days is already too long to go between shots. And so I think to delay beyond that is really potentially detrimental to their quality of life at the very least. I'll also say, as a general answer to both shots and scans, we're trying to reduce the number of touches in the healthcare system, meaning the number of visits where, again, patients have to come to our centers. So to that end, I believe both Novartis and Ipsen, so the manufacturers of octreotide or sandostatin and somatostatin or lanreotide respectively, both have home injection programs. And I think the longer this goes on, I think the more we'll see people engaging with that. From what I understand so far, not every patient is eligible. However, it is potentially worth your audience asking their oncologists if that's an option for them. And my understanding is, if that is an option, highly trained nurses at the delivery of somatostatin analogs will then come to the patient's home. And I think that's potentially quite advantageous to keep them on track with their analog schedule, but not have to bring them into an infusion center or a hospital. As far as scans are concerned, again, it depends on sort of the acuity or threat of the disease. If you're someone that's dealing with a high-grade neuroendocrine carcinoma with liver metastases, your scan is one thing versus, say, someone that's on surveillance, perhaps for a lower grade NET. And again, that's a discussion we need to have with your oncologist. Talking to colleagues around the country, I think many of us are perhaps carefully postponing routine surveillance scans by a couple months, again, to sort of unburden the healthcare system and also, and more importantly, to protect patients. And if they don't have to come to our centers right now, they really shouldn't.
What about PRRT? We've heard from patients who have had 3 of 4 treatments. We've heard from patients who have just had their first treatment. This is obviously a concern.
Yeah, so I can speak here as a physician at my center. I'm sort of the gatekeeper for PRRT as a medical oncologist. So I work closely with my nuclear medicine colleagues, but it's sort of been up to me to triage patients. And PRRT is a valuable and limited resource. So already I had sort of a queue of patients in terms of who was starting. I'd say that the calculus for starting PRRT now looks a little bit different, and we have to be pretty confident that the disease is threatening enough that we need to get PRRT started either for stability or ideally later on response. For people that have already started though, and again, Elyse, I'll say that this is early April and this might change. Right now, I've been inclined to continue really for 2 reasons. Number one, if we stop or postpone, in your example, say that 4th treatment, we're really deviating from our evidence base. As you know, the NETRF trial was really seminal in getting lutetium-based PRRT going in America. And so we don't have a study that shows the outcome if you do, say, only 3, only 2, or only 1. So it's always a little bit dangerous, and it happens in the real world all the time, but it's always a little bit concerning when you deviate from a standard like that. We just don't know then how that affects outcomes. And secondly, PRRT is, as you know, an every 2-month treatment. And so you don't have to bring the patient to your facility that often. And I know when they're here, it's a very intensive day of treatment, but I'll also point out it's a day where they are largely sequestered. So unlike, say, an infusion center where there may be dozens of other patients around you getting their infusions, in PRRT, it's actually a very lonely day because of the radiation. So all that put together, my inclination so far has been, if you're already on PRRT, we've been continuing. And again, that might look different a month from now, but right now that's what we're doing.
Do you think that might be different regionally in the United States, depending on how the surge is progressing in some of those states?
That's an excellent point, Elyse. Yeah, so I guess I should say and recognize that PRRT is very resource intensive. So here at Intermountain, when someone is coming for PRRT, they actually have a higher level of nurse staffing than you would get in the intensive care unit. You have a nurse dedicated to you and you alone the entire day, whereas in most ICUs, it's a 1-to-2 ratio of nurse to patients. So presumably in, say, hospitals in New York right now, where it's all hands on deck, there almost certainly would not be staffing or bandwidth to proceed with PRRT. And frankly, I probably should reach out to my colleagues at Sloan Kettering and other New York facilities to see how they're handling that. Here in Utah, so far, we've been fortunate that we have the staffing still to continue our routine nuclear medicine procedures. And I should point out also, at our institution, until we're at 75% ICU capacity, all cancer care will be not deemed elective. So what that means is until we hit a certain threshold where we really need to divert almost all of our resources to critical care, cancer patients are not being delayed or postponed if we can at all avoid it, because we realize that there's competing threats here. There's the risk of the viral pandemic, and there's the risk of unopposed cancer. And right now, we're trying to balance both and not put patients at excessive danger of the virus, but also not allow their cancer to go unchecked. So that's what we're doing at the moment.
But that could differ depending on where you are and where you receive your care.
Precisely.
Are you noticing or aware of any drug shortages that would impact neuroendocrine patients, either in terms of supply or access?
Well, it's getting pretty hard to find hydroxychloroquine and azithromycin. And actually, we're running, I shouldn't even joke about that because it's a serious problem for people with rheumatologic conditions who rely on hydroxychloroquine for safe control of their lupus or rheumatoid arthritis. We're actually running clinical trials of those agents for what it's worth. In terms of other drug shortages, Elyse, not yet. I can foresee a scenario where supply chain gets so overwhelmed that some drugs might start to become more scarce. But as far as I'm aware, Novartis and Ipsen still have a robust supply of somatostatin analogs. I'm not aware of shortages of any other drugs that we would routinely deploy in neuroendocrine tumors. So I think so far so good would be my cautious answer there.
I also know that you've been using telehealth, and that's something that has been available in Intermountain for quite a while.
Yeah.
As other clinicians and other institutions try to implement telehealth for patients, what suggestions do you have for patients to adjust to this virtual appointment, and also to make the most of that appointment, because it's very different than being in the exam room?
It is. I will say, and I don't say this lightly either, so out of almost every major catastrophe, there's usually a medical advance. So, and this may be a stretch, but out of World War II, penicillin sort of took hold widely. And I sort of wonder if we won't look back after this pandemic, which hopefully will be over sooner rather than later, and realize that this has really shifted medicine to embrace telehealth more. I actually think it's a wonderful tool. I've been using it for some time. And as you mentioned, Intermountain, where I work, is based in Salt Lake City, so a metropolitan area. But we actually reach out to essentially a 5-state region into the rural and frontier areas. And so I've been doing this with patients for a while now, for people that, for whatever reason, it wasn't convenient or possible for them to travel to my clinic. So all that being said, this is a new era where we're using this technology sort of because we have to, necessity being the mother of invention. But it is extremely rewarding. And I think so the first thing I'd say to patients is, go into it with an open mind. I think you might be pleasantly surprised how much you can get out of an interaction. I talk to my patients every day, just like you and I are talking now. You're right that it's not the same as being face-to-face in the clinic. There's, a je ne sais quoi that's missing. You can't put hands on. You can't, reassure someone if they're dealing with bad news. Even if they were in clinic right now, I can't, hug someone going on hospice like I normally would. But I would also be proactive. So make this a two-way street. The way we've been doing it here is every week, all the docs in my clinic, and I work in an 8 oncologist practice, we actually sort of triage our list of patients for the week, and we ask ourselves, whom among these people is appropriate for a video visit? And then we make the necessary arrangements for that to be set up. Now, I do realize there's a disparity here. Not everybody has a smartphone or a computer, and not everybody is technologically savvy. So we actually have tried to reach out to people the day before, troubleshoot those issues. Occasionally, a grandchild has helped a grandparent figure out their iPhone. So that's been kind of cute to see. But what I was going to get at is, it's not wrong. Yes, clinics are very busy right now, but it's not wrong to call your clinic and ask, hey, is this available to me? And I would say at the very least, and I've done this in some occasions too, even a phone call, it's not quite as meaningful as what we're doing now. A phone call can go a long way. And in fact, when time permits, even without a formal visit, I've tried to call some of my patients and sort of check in. People that I know were already having a hard time, emotionally or psychologically before all this. As you can well imagine, this has just heightened everything. We are seeing, unfortunately, higher rates of anxiety and depression, which I think are important comorbid conditions, especially with NETs. And so don't be afraid to ask. I don't think there's any harm in asking if telehealth is right for you. And again, I think once you try it, I think you'll be quite pleased. And I'll say this too, almost without exception, every single patient who I've done telehealth with has thanked me. And that's not, that's not me boasting. It's because right now they really don't want to come into clinic. They don't want to put themselves at undue risk. And so they're actually thrilled that we can have this connection and not have to have that person-to-person contact.
That's great. It's good that that's a new tool for a lot of people.
Yeah.
There's been discussion just in the last couple of days, and I know that you and your wife were kind of out ahead of this trend of people making masks.
Yes.
If there is a mask advisory that people should wear masks when they go outside, one of the things I haven't heard is should people be wearing that mask anytime they step out their front door? Should they wear it when they walk the dog going around the block and they don't see another human being? And how do you maintain the mask so it continues to be safe? Do you have some suggestions about that?
I do actually. So in preparation for this conversation, I actually reached out to one of the infectious disease specialists here at Intermountain, who's an expert on viral transmission. And so he said a couple of very interesting things that I want to repeat for your audience. Number one, nothing is a substitute for social distancing. So no matter how fancy we get with masks and N95s and drugs like hydroxychloroquine, the virus can only spread person to person. And as you know, it's a virus that spreads via droplets. So either you are, and I know this is getting a little gross, but either you're exposed to someone else's respiratory droplets, or those droplets have landed on a surface and are sort of waiting there, if you will, until they can move to a human host. So a couple points. The social distancing, that this business about staying 6 feet away from people, that is roughly the range, and again, this is kind of nasty, but that's roughly the range of respiratory droplets when someone coughs or sneezes. Okay, so that's, the 6 feet thing is not arbitrary. And then the whole business about washing our hands, very conscientiously and cleaning surfaces, this virus is actually extremely vulnerable to soap. So the virus has a capsule around it made of lipids, and so they're kind of like tiny little fats, and those are disrupted by soap. So again, it doesn't have to be fancy. This is where washing your hands for 20 seconds is crucial. And then in terms of surfaces, it depends on what surface the virus has landed on, but it is actually quite prone to drying out. And again, the virus needs us. It needs us as a host if it's going to survive. It cannot survive on a surface for too long. Sort of the scarier studies say that on certain surfaces, I believe plastics in particular, it can persist for up to 72 hours. But on the flip side, there's other surfaces like I think copper where it can only last for a couple hours. Regardless, and I am getting to your question. Nothing is a substitute for social distancing. I cannot say that enough. So the mask business, in your example where you're walking the dog and no one else is around, which I'm certainly doing in my neighborhood, I don't think you need a mask, frankly. The difference is if you are having a respiratory symptom, so if you're coughing or sneezing, the mask is largely for other people's protection, okay? So that, again, is almost like a physical barrier to prevent the droplets from spreading. Now, the virus itself is pretty sneaky and small. The virus is 0.1 microns wide. So let me do the math here in my head. That is 1/10 of 1/millionth, I think, of a centimeter. Don't quote me on that. I may be off there, but it's very, very small, okay?
Can't picture that.
Yeah. And even N95 masks, so to the N95, what that means is a mask that excludes 95% of particulate matter down to 0.3 microns. So what I'm really getting at here is the virus is so small that if you put the virus directly on an N95, it can still get through those holes, okay? So regarding your question about like mask reuse, so for most people, because you just need a physical barrier, this recommendation about bandanas and scarves, it's not ideal, but it's actually not a bad idea if all you're trying to do is prevent spread. For healthcare workers, it's a little bit different. If we're going from room to room and constantly at risk for contracting it, we really do need higher grade equipment. And that's where this whole movement about, get us PPE, which is personal protective equipment, that's where that's really come into play. So I think the one thing I would advise people not to do is if you can avoid buying medical grade supplies, I know it's a selfless thing to ask you to do, or a selfish thing for us to ask you to do, but it really is important that we still have access to those supplies, because ultimately then we're protecting you. And finally, Elyse, maybe I can send you the link to the video or the tutorial that my wife put together. So my wife is a pediatrician. She's brilliant. My mother is a wonderful seamstress, my mother-in-law, excuse me. And so together they came up with this design where it's essentially a reusable mask where there's a pocket to insert a filter. So again, the cloth itself is not medical grade, but you can put in there a filter that's either a higher grade mask, like a surgical mask or an N95, or a material that is a better barrier against these particles. So believe it or not, vacuum cleaner bags, which I know sounds bizarre, might actually, as a non-woven fabric, might actually exclude virus better than other insertion materials. So anyway, I'm more than happy to provide your audience with those links.
That would be great. Thank you. So some other questions. Patients have said if they unfortunately have to go to the hospital or to an emergency room, what should they prepare? How do they notify the staff of their condition if they have a NET? And I think there's a fear that an emergency room staff may not understand neuroendocrine tumors or carcinoid crisis or other factors that would influence care. What do you recommend as a patient and as a physician?
Yeah, well, I think that's actually been a concern for a long time that's now just amplified in the midst of this pandemic. So I'll say two things. So I can look at this from both the patient side and the doctor side. I know a lot of patients already wear sort of a medic alert bracelet that says that they are a neuroendocrine patient, particularly if they've had or are prone to carcinoid crisis. And then on the physician side, you got to remember that right now, like literally number 1 through 10 on every doctor's diagnostic list when you come into the emergency room is COVID-19. That is understandably the prism through which they are going to view you. So NETs and carcinoid crisis are, and I don't think this is the physician's fault, probably going to fall lower down on their list of considerations. And so the best thing in medicine, and I've said this before and I really mean it now, is the self-advocating patient. Gone are the days where it was paternalistic and doctors didn't want to hear from you, we were going to tell you what to do. It is very much the era of shared decision making. And so the best thing you can do is advocate for yourself. You're not being difficult, you're actually being helpful. If you tell your doctor, hey, I've had carcinoid crisis before. I've even directed colleagues that have called me from emergency rooms. I've walked them through various protocols. Dr. Woltering has a pretty famous protocol for management of carcinoid crisis. And again, we live in the information age, and so you just have to direct the doctor or your medical team to the right resources, and then take it from there. But don't feel like you can't voice your own concerns. My wonderful late Scottish grandmother had a heart attack on a Sunday and didn't tell anybody until the Monday because, quote, you don't bother the doctor. I love my grandma, but that was the wrong thing to do. You can very much bother the doctor with information that could potentially save your life. So please, please speak up if you think they are overlooking the potential for carcinoid crisis.
And along with how to plan for emergencies, what are some of the important discussions that families should be having at this moment? And I pose that question to you again as a patient as well as a physician.
Right.
Some of the stories we've heard about COVID patients who have been hospitalized and they haven't had access to family members. They're not able to speak because they're being placed on ventilators.
Yeah.
What kind of lesson does that send to all the rest of us?
Yeah, no, thank you. And I know this is going to potentially end on what might sound like a morbid note, but I think this is super important to talk about. And it's not easy to talk about. As much as possible, communicate to your family. And this goes for whether you're a NET patient or a caregiver, because this is a disease that unfortunately does not seem to discriminate very much. Communicate what you would want done. There's a lot of sort of horror stories about rationing and are we going to have to make, decisions about who gets the ventilator, who doesn't? There are, unfortunately, scenarios where we are so resource poor that we're having to make those decisions. And I know that evokes talk of death panels and doctors violating our ethical responsibilities. The main way that we can honor your wishes, that we can put your autonomy number one, as we always try to do, is if you have in writing expressed your desires. Okay. And the other thing I'll point out is that doesn't just help us, that also unburdens your loved one from having to imagine what it is that you want. So, if you're fortunate enough to have a spouse or a loved one who's your surrogate decision maker, I actually think you owe it to them to tell them what you would want done and then write it down. And again, I can provide links for advanced directives. Those are a little bit tricky because they tend to vary by state. But again, it's not too tricky online to find the regulations and forms for your state and fill them out accordingly. And I can also say, Elyse, on the physician side, it is so helpful if a patient has done that, again, in advance, rather than waiting until they're in extremis, when obviously things can look a little bit different. And I know that, I know this all sounds morbid. It's important to remember, as you pointed out, that when you're on a ventilator, there's a tube down your throat. You may be sedated for large periods of time because that's uncomfortable, and you will not be able to speak. You will not be able to verbalize. So the writing part is super important. I will say also, to kind of lighten the mood, it is possible, in some cases likely, that the intubation will be temporary. So I'm happy to share so far, and again, this is very early data, here at Intermountain in my hospital this week, what I've heard is 80% of the people who went on the ventilator have now come off the ventilator. Now, unfortunately, numbers across the country are not nearly that hopeful. And so I think in New York and really hard hit areas, unfortunately, the rate of extubation or coming off the ventilator has been a lot lower. But here so far, we've been fortunate that the ventilation is temporary, which is the ideal scenario. If you need the ventilator, we don't want to have you on it forever. And obviously, we don't want you to pass away in spite of maximum respiratory support. So a tough note to end on, but I think it's really important to talk to your family. My wife and I are physicians. We literally had this conversation earlier this week. We're not immune to this either. And I just encourage everybody to take the time. And again, ideally write it down on a valid form, and I'll be happy to provide that link.
Thank you. We do have one last question, though. That was question 9. What suggestions do you have for coping with the stay-at-home restrictions? You're a physician, you have kids, you're trying to keep the household going, you and your wife. So what little things have you found to bring you joy through all of this?
Yes, well, as you know, Elyse, I have dogs. So taking the dogs on a walk has been really a really nice way to get outside. And again, as we said earlier, provided you're still following the social distancing guidelines, a walk is not a bad thing. The virus does not hang in the air. Okay, it's not atmospheric like that. The only way it gets aerosolized is if again you're in a very high risk procedure like having the tube put down your throat. So people should not be afraid, I don't think, to just go outside. And that's been enormously helpful. I have a very energetic 9-year-old son, so it's helped to run him around and work off some of his excess energy. But the other thing I would say is, at this moment in history, we have such potential for connection virtually. So the internet is not unequivocally wonderful. There's a lot of bad things about it. Even these days, I'm sort of shocked and ashamed by the amount of vitriol you can find in certain corners of the internet. However, it is a wonderful way to stay in touch with people. So my mother is out of state. I FaceTime with her. My friends who are in other states, literally earlier this week, we hung out using Zoom. So there's a lot of ways you can stay in touch. And so I would just encourage people to remember that although we're physically separate, we have these really neat ways to remain in contact. I don't think there's anything more heartening than talking to a friend, making sure that they know you're thinking about them and vice versa.
Thank you, Dr. Lewis. I think that's a good note to end on.
Yeah.
We want to thank you and all of your colleagues, all the NET specialists and team members across the country who are doing so much now to try and keep everyone safe and healthy. So all the best to you and your family.
Thank you.
And thank you for your time this morning. I do want to just share, if people want more information and would like to go to our website, then they can go to netrf.org. We have an orange banner for COVID-19 and all the information that we are posting. And it does change from time to time, so please check us out. And again, thank you all for being with us today. Thank you, Dr. Lewis.
Absolutely. Thank you. Stay well.
You too.